exploring intraprocedural performance in colonoscopy, insights from a tertiary care center in Saudi Arabia. So colonoscopy is essential for diagnosing and managing colorectal condition. It's recognized as the gold standard for early colorectal cancer detection, as well as removal of pre-malignant lesions. The American Society of Gastrointestinal Endoscopy have established benchmark indicators to minimize the risk of interval colorectal cancers. Despite their importance, research on these metrics in Saudi Arabia is limited. In this study, we aim to analyze the key intraprocedural indicators of colonoscopies to evaluate adherence to care standards. In our study, we adhere to the ASGE 2014, which was the most updated guideline at the time of our study. It's a retrospective study, examined 3,767 colonoscopies at Johns Hopkins Aramco Healthcare in Dhahran from the period of January 2021 to December 2022. We included all colonoscopies performed by adult gastroenterologists between the defined period. We excluded those under the age of 14, procedures carried out by pediatric gastroenterologists and colorectal surgeons. Our primary outcome is to assess the intraprocedural performance to evaluate adherence to care standards. Additionally, we analyzed the metrics based on the indication of the procedure and determined the predictors that might influence the outcome. We employed Fisher's exact test and chi-square test to examine the significance and association between categorical variables. We employed as well regression analysis to predict the outcome and calculate the odds. A p-value of less than 0.05 was considered statistically significant. While analysis in place, let's highlight the demographic data and study results. The mean age was 54 years, male accounting for 55%. Additionally, 81% of the population were Saudi citizens. Moving to the main part, which is the intraprocedural performance, the mean withdrawal time of the procedures was 10 minutes, which aligns with the ASGE of a minimum of at least 6 minutes. The overall polyp detection rate was 33%. The overall adenoma detection rate was 23%, regardless of the initial indication of the procedure. Cecal intubation reached in 93.6% of the procedures, which aligns with the ASGE of at least 90%. 88.9% of colonoscopies were scored more than or equal 6, which again aligns with the ASGE standard of at least 85%. When analyzing the metrics based on the indication, screening colonoscopies has a higher adenoma detection rate, polyp detection rate, cecal intubation, and postal polyp preparation scale when it's compared to the non-screening indication with significant p-value. When further looking into the adenoma detection rate, it reached the target for the screening, which is the minimum of 25%. When further dive into it and dividing it based on the gender, male population reached 29%, which almost reaching the minimum standard of at least 30%, while female reached 20%. Regression analysis were performed to examine the factors influencing the outcome over the adenoma detection, polyp detection, cecal intubation. The key findings were those who are male, elderly, and having screening indication are more likely to have adenoma detection, polyp detection, and cecal intubation. And those who are having post-bowel score more than or equal 6 are likely to reach the cecum. In conclusion, colonoscopies adhere to standards of care. However, the ASGE a few months back updated the quality indicators and further refined and enhanced these metrics, so more efforts needed to reach the new update and targets. Further research is necessary to evaluate pre- and post-procedural parameters to enhance colonoscopy practices. By this, I concluded my presentation, and thank you all for your attention.
Okay, thanks so much for that great presentation. The next presentation is titled Evaluating Upadacitinib in the Treatment of Moderate to Severe Active Inflammatory Bowel Disease, a prospective cohort at a tertiary care center in Riyadh. This will be presented by Dr. Hisham.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Hisham Al-Maili. I'm an internal medicine resident in King Fahd Medical City. Today I'll be presenting our interim study, which is the evaluation of abatacetinib in the treatment of moderate to active or to severe inflammatory bowel disease. Starting with a little bit of a background, as we know that abatacetinib is a second generation Janus kinase inhibitor, mainly targeting the JAK1 enzyme. It's an FDA-approved medication for the treatment of multiple of inflammatory processes, among of which is the ulcerative colitis and Crohn's disease. We have a limited real-world data regarding the treatment of abatacetinib in such patients, especially in Saudi nationals. Hence our objective. We wanted to see its clinical effectiveness and safety. So when we started our study, we had two endpoints, a primary and a secondary endpoint. Our primary endpoint was to see the clinical effectiveness by using the Lich-Tiger score for ulcerative colitis and Crohn's disease activity index for Crohn's disease patients. Our secondary endpoint mainly targeting the symptomatic improvement for such patients and using the endoscopic Mayo score for ulcerative colitis patient and eventually the safety outcomes and adverse events. So our study is a prospective cohort study cited in King Fahd Medical City. We started our study in September 2023. We included adult patients who have been diagnosed with ulcerative colitis and who have failed multiple lines of treatment. So we have a total of 26 patients in our study, 18 patients with ulcerative colitis and 8 patients with Crohn's disease. All of whom are Saudi nationals with equal male to female distribution. What we did is that we introduced all the patients to abatacetinib and followed them at different intervals, at 2 months and 6 months for ulcerative colitis and at 3 months and 6 months for Crohn's disease patients. So moving along to the clinical effectiveness of ulcerative colitis, going to the Mayo score actually, initially, we have 93% of our patients were having a Mayo score of 2 and 3. By the end of the 6 months, 53% of our patients were having a Mayo score of 0, and 23% of our patients were having a Mayo score of 1. Here are graphs also explaining the Lich-Tiger score. We have noticed that by the 2-month mark, we have a decrease in the mean by 5.5 in comparison to the induction time. And by the 6-month mark, also a decrease by 6.2 in comparison to the induction time. So for clinical effectiveness in Crohn's disease, what we have used is the clinical disease activity index for Crohn's disease. We have noticed that by the 3-month mark, there is a decrease by 243 points in comparison to the induction time. However, by the 6-month mark, there has been variation with 2 patients, so the score elevated a little bit. So going to the safety profile, we have 12.5% of our Crohn's disease patients have developed a lipid disorder. We have 26% of our patients with ulcerative colitis also have developed a lipid disorder, and 5.9% of our ulcerative colitis developed shingles infection. However, no cardiovascular incidents, no hematological or infectious processes has been noticed in patients. So our study faced a number of limitations, the fact it's being a single-arm study with a limited number of patients. However, our data supports the usage of abatacetinib in patients with ulcerative colitis and modest, though variable, for Crohn's disease patients. What we're going to need is a larger and longer studies to recommend and validate our findings and explore treatment options. Thank you.